A 32-year-old private pilot flew with 3 companions to a mountain resort for a weekend of skiing. The unpressurized flight originated at sea level and terminated at an airport with an elevation of 7,200 feet. The ski lodge was located at just over 9,000 feet MSL. After arrival, the airman exercised in the lodge's fitness room, stayed up late, and rested for about 4 or 5 hours. In the morning, he worked out for another hour and then enjoyed a day of skiing with several excursions to the summit. The next day, the pilot awoke feeling extraordinarily tired with no appetite. He also complained of shortness of breath and decided to skip the second day of skiing. Throughout the day, he became progressively weak and lethargic. When his friends returned to check on him, he was obviously having difficulty breathing and looked cyanotic. One of his friends, an aeromedical examiner, insisted that they call for an ambulance. The ambulance transferred the pilot to a local clinic on 100% oxygen, where examination revealed pulmonary ralls, dysarthria, and ataxia. Pulse oximetry showed his PaO2 was only 45 milligrams of mercury on room air. Arrangements were made to transfer the pilot to a medical center at lower altitude where the neurologist noted progressive disorientation and papilledema. A brain CT revealed a decreased volume of the ventricles. He was treated with high-flow oxygen and dexamethasone. He recovered fully over the next 3 or 4 days. Welcome to Aerospace Medicine Grand Rounds. Speaking about this case today, we have Dr. Roger Bisson from the Civil Aerospace Medical Institute. Please welcome Dr. Bisson.
This airman was very lucky. Had he lost consciousness at altitude, or if treatment was delayed, he probably would have died within 6 to 12 hours. Altitude Induced Illness is caused by a rapid ascent to high altitude. Common symptoms include headache, general malaise, fever, weakness, dizziness, and lethargy. Physical findings can vary, but may include cyanosis, pallor, periorbital edema, and tachycardia. High-altitude pulmonary edema occurs in unacclimatized individuals who ascend rapidly and engage in physical activity. The physical exam will reveal gurgling sounds in the lungs, and the individuals are often coughing up large amounts of fluid. A chest X-ray will show patchy infiltrates starting at the bases and maybe up into the middle of the lungs, but the apices are generally clear, and the cardiac silhouette should be normal. The very low arterial oxygen explains why the individual is so mentally obtunded. A fundoscopic exam will reveal retinal hemorrhages. Immediate treatment is 100% oxygen, and this needs to be by high-flow mask at least 6 to 8 liters per minute, and a non-rebreather mask if possible. And of course, you want to bring the individual down to a lower altitude. In addition to high-altitude pulmonary edema, this individual seems to have had some high-altitude cerebral edema as well, so the prompt administration of dexamethasone to relieve cranial swelling was very important. Does anyone have any questions?
Why did they not treat him in the hyperbaric chamber?
I don't know why they didn't treat him in a hyperbaric chamber. Perhaps they didn't have a monoplace chamber available, or it was too far to get to a multiplace chamber. Treatment in a hyperbaric chamber would have been very useful in this man's recovery. Any other questions?
If the pilot has no neurologic or other residual effects, when should he be permitted to fly again?
It probably would be prudent to not fly for a couple weeks following an incident like this. A special issuance, however, is not required unless there is a neurologic residual. Does anyone else have a question?
Is high-altitude pulmonary edema or high-altitude cerebral edema essentially the same as type 2 decompression sickness?
I'm glad you asked. High-altitude pulmonary edema or high-altitude cerebral edema are certainly part of the decompression illness or decompression sickness continuum. Treatment of decompression illness is always 100% oxygen and transport to a hyperbaric chamber, and that's really what I want to emphasize. When you use the terms type 1, simple bends, or type 2, neurologic, there can be some confusion. Although these terms, type 1 and type 2, are still used, I prefer to use more descriptive terminology of the actual manifestations that the patient is presenting. There's just too much overlap between type 1 and type 2. Decompression illness, of course, is the broader terminology used to describe decompression sickness because it includes arterial gas embolism as well as simple joint pain, the bends, chokes. There's a cutaneous manifestation of decompression sickness called the niggles. There's purely vestibular manifestations called the staggers, or you can have neurologic decompression illness, but they all can overlap. Aviation medical examiners really should be familiar with all the manifestations of decompression sickness and have a very strong index of suspicion of an airman who presents with symptoms following any exposure to 18,000 feet cabin altitudes or higher, or if they give you a history of flying after scuba diving. The FAA recommends no flying 24 hours after scuba or high-pressure chamber exposures. As this case illustrates, rapid ascent to even more modest altitudes, especially with a history of exertion or exposure for more than 1 or 2 days, can result in very serious decompression illness. Increasingly, we do see operational ceilings above 55,000 feet. At these sorts of altitudes, there's an immediate off-gassing called ebulism, which can be a very serious manifestation of decompression sickness. Prompt treatment, once again, 100% oxygen and hyperbaric chambers can result in remarkable recovery, and delayed treatment, even for a short period, can result in long-term disability or even be fatal. Had to compress a lot of information for a very short presentation. Thank you very much for your attention.